It's my pleasure to introduce Christine Burion Cook. She is the Director of Clinical Research and Services in the College of Health Sciences at the University of Delaware. She has been a member of Delaware's Parkinson's Disease Task Force and has held various offices in Delaware Speech, Language, and Hearing Association, DHSA. She is a steering committee member of the Delaware Telehealth Coalition and is a member of the leadership team at the University of Delaware Center for Interprofessional Development, Education, and Research.
Hello, everyone. I have the distinct pleasure of being the speaker between you and lunch. So I'm going to do my very best to keep this talk engaging and paced well. So as it was shared, I am Christine Cook. I am the Director of Clinical Research and Services for Communication Sciences and Disorders, which is for our budding speech language pathologists. Something that's not disclosed on this slide is that I started my career at Christiana Care, so it's really cool to be standing up here. And I will share that so much of what I learned and what I try to impart on the graduate students who are now like your seasoned clinicians is that we have to work together, right? And I learned all of those lessons on the ground floor with a lot of the stroke team folks here at Christiana. So thank you for that. All right, so I want to level set first and make sure that we're all on the same page in regards to what is aphasia. So it's any difficulty understanding or expressing language following a neurologic event. And so I want to unpack the definition a little bit because I think us SLPs just assume that everybody thinks in the same way that we do. But when we think about understanding, it is in part what I'm hoping is happening now. So I'm speaking and you're understanding what I'm saying. But we also have to think about being able to read and understand what's given to us in written form, as well as with gestures, sign language, and even body language and some of those pragmatic cues. Whereas expressive language is being able to find words, right? I think we all know that that is a hallmark of aphasia. We also have to consider a person's ability to write and to be able to express, for example, in sign language with gestures or with some of those extra linguistic features. So these statistics may not look super, but I'm actually very excited to share them with you in some way, shape, and form. So in the National Aphasia Association usually does an awareness survey every 2 to 4 years, and they sped this one up. Unfortunately, because Mr. Bruce Willis has been diagnosed with aphasia and there was so much press around that, now we can more confidently say close to 70% of the population have actually heard the word aphasia, and about 40% know it's something to do with language. And this is actually a significant increase from 2020 when those reporting percentages were 13 and 7% respectively. So we have an image problem. We need to kind of spread the word about what aphasia is and also what it is not. So on behalf of my patients with aphasia, I want to make sure that this room knows and beyond that aphasia is not a deficit in your intellect, right? It's a decreased access to language, but it does not impact intellect. So it's something about presumed competence that we as healthcare providers need to consider when working with our stroke survivors who have aphasia. So there's some incidence and prevalence statistics here. I think the thing that really gets me is that 1 in 3 stroke survivors, 1 in 3 will have some form of aphasia. So think about your caseloads, right? That's like, I mean, depending on who you're seeing every day, and it may not be the obvious person, right? So there are folks who have global aphasia in which they're really not able to share anything verbally and have difficulty understanding, but it could be somebody who's got more subtle difficulties. So when you're having that banter chit chat, how are you feeling? How have the medications been working? Have you been doing your home exercises and going to therapy? Those conversations are fine. but it may be when you start to dive in a little bit more and ask, okay, what questions do you have for me? Or how much do you understand about managing your stroke risks, that you start to see some of that communication breakdown. And we know that with aphasia, these folks are at a higher disadvantage or a higher risk for poor health outcomes, right? So folks with aphasia, and this actually extends to anyone who is an adult with a communication challenge or a language that is different from the provider's dominant language, they are at 3 times more likely to experience a preventable adverse outcome. 3 times, just because of that communication difference. They're often more likely to be dissatisfied with care. They have poorer health outcomes and a higher utilization of healthcare services. Higher utilization means higher costs for the administrators in the room, right? And for my physical therapists, they also have a higher risk of falls. And for the rest of the medical team, that leads back to that readmission rate. And I also want to acknowledge that as a healthcare provider, as a speech pathologist myself, I can acknowledge that caring for someone with aphasia can be really difficult. It's time consuming, right? You can't just give the same spiel that you gave to 602 to 603 with aphasia, because we have to consider how they're processing and responding to what we're saying. And we want to help, right? We are helping people in healthcare, but we don't always know how to help the person in front of us. And that's in part because aphasia can be highly variable. My graduate students hate this, but I feel like one of the takeaways is always with aphasia, they want the answer, right? And there's never an answer. So we frequently say, it depends. And they're like, oh, come on. But that's the God's honest truth, right? It really depends on who's in front of you. And at times, and these have been documented in studies, so if this resonates with you as something you've maybe thought in the past, know that you are seen with this study. Sometimes we limit the amount of time we spend with our patients with aphasia, either because there's a communication breakdown or because we think like that's enough. We've given you enough information for that point in time. So that's tricky. And what's trickier is that our stroke survivors with aphasia, they feel this, right? They know that this is hard work for us as a healthcare professional. And so these 2 vignettes are pulled out of this team of folks. Worrell and her colleagues have done many studies looking at quality of life with aphasia. And so this first anecdote has to deal with a patient who had chronic aphasia, was admitted for a cardiac procedure, and was given the instruction, hug the rolled towel when you cough so you don't pop your stitches, right? That seems pretty straightforward to us. That's like 9 bits of information. So for someone with a receptive aphasia, and in this case, this woman's husband, he really had a difficult time caring for himself after the cardiac event. The second vignette, I really, this hits home to me because of COVID, and I'm preaching to the choir, right? But how many of us had to treat a person with aphasia in isolation, right? It's not that they didn't have a care network around them. It's that for infection prevention reasons or, visitor limitations, we weren't able to have people in the room. And so I often think we may be seeing some ripple effects of this in years to come, because we haven't been able to effectively communicate, hey, what's going to keep you out of the hospital to prevent the recurrent stroke risk? And even within the umbrella of aphasia, there are disproportionate impacts in terms of care prognosis, right? So in stroke overall, we know that Black Americans are at a higher risk of stroke. Within aphasia, we are also seeing a growing body of literature that supports that Black Americans and individuals who don't identify as being in a white body have poor health outcomes in chronic stroke recovery. That's a problem. And this is a preprint study that I would strongly encourage you to take a look at. It'll come out next month. But this is the neurology team at Georgetown who was actually able to correlate different outcomes on behavioral testing with the same size lesion, and one of the only differentiating factors was if they were a Black American or a white American. So we have room for improvement. We know our folks with aphasia are at a disadvantage in terms of their healthcare outcomes, and even within that umbrella, there are populations of folks who are at an even greater risk for recurrent strokes and for adverse effects. So I'm not a monster. I'm not going to leave you like that and say, okay, go have lunch. I'm going to try to give you some kernels of wisdom. Wisdom might not be the right word, but some strategies to work with so that you and your respective, stroke care team positions can hopefully deliver your messages and communicate with your patients as effectively and efficiently as possible to try to minimize some of those risks that I alluded to in the first few slides here. So, keeping an eye on my time, I want to acknowledge my colleagues, Dr. Helen Mock. She has actually left the University of Delaware and is now working with the Center for Policing Equity, doing language and policy work in Philly, which is super cool. And my colleague who I get the opportunity to teach the aphasia class with at the University of Delaware, Dr. Rebecca Hunting-Pompon, is actually probably just wrapping up facilitating a caregiver and stroke survivor group at Temple University's Aphasia Fair, like right now, where they're talking about quality of life and outcomes ahead of the Academy for Aphasia meeting that starts tomorrow in Philly. So her work really centers around how stress, depression, and resilience impact recovery trajectories with aphasia. And so I will strongly plug her lab website, not just for studies, but for resources. She's got really great, accessible, important resources. So they put together this work. Helen was able to create a framework from a lot of colleagues' research that helps us to support our patients in understanding our message and communicating back to us what they do and do not understand. So we'll talk through this today. And the acronym is called FRAME, okay? So we'll go through each of these subparts briefly. Some of this might be intuitive to you, and then there are hopefully a few tips and tricks that you'll walk away with today and say, I'm gonna try that, every third patient when my stroke survivor on the list has aphasia. So first is familiarizing yourself with the patient or client's communication preferences, right? So if you walk in a room and you go, how you doing today? And they give you a thumbs up, that tells you something. What could that tell you? What might they enjoy doing? I'm sorry, that's right. You aren't graduate students. You're not beholden to respond or lose points. But I think it does tell you that maybe gestures are an effective way of communication for them, right? So that may be an inroad for you as the provider to start considering how you're communicating with them, right? There are lots of supports, right? If they start to error write, and some people can do this very effectively and spell with their fingers, please have a piece of paper and pencil for them. Make their lives easier, make your lives easier, and give them those communication supports. And then I think there's one more point on here, but this one here, where you ask your patient, hey, is it okay to guess rather, or do you want me to wait until you finish? It's so important, because if we just jump in because we hate to see people struggle, right? We're taking away a really important communication opportunity from this person and maybe overstepping in a way that doesn't feel good to them and your rapport, right, between patient and provider. So by asking, it gives you a leg up to figure out, how can I best communicate with this person? And for the love of goodness, please ask them, where are your hearing aids? Do you have them? I can count on two hands the number of times folks have been diagnosed with a receptive aphasia and in fact needed hearing aid batteries. So just good things to check. R stands for reduce your rate, which I am not doing now. But this applies not only to reducing how you communicate in terms of your pacing of speech. My colleague Rebecca talks about starting slow and then modulating your rate up or down depending on how the person responds to you, right? This also applies to how we listen. Ooh, that's a hard one. So you may have to just be very patient. Like I've had to train myself sometimes to count internally to 5 or 10, knowing that this person will respond to me. It's just going to be outside of my normal communication give and take, my usual communication give and take timeline. And try to maintain eye contact if that's culturally appropriate with your patient so that they know I'm with you, right? We can do this together. So assisting with that communication. And again, this can literally be anything that you have to communicate about when you're talking to someone with aphasia. So ask your questions in different ways, give multiple choices, and try to write down a couple words just to be like, okay, did I get this? The stories I could tell about sometimes you assume somebody's going in one direction and then whoop, they come out with something totally different. You just never know what to expect, right? That's the beauty of being able to be flexible communicators. Again, another takeaway, and PWA stands for person with aphasia. Let them know when you don't understand. This harkens back to my first slide. Aphasia is a difficulty accessing language. It is not a decrease in intellect, right? These folks are smart. They know when people are just and giving them that line because they don't want to engage and say, I don't get it, right? And give them a little bit of a heads up. So say, I got this part, but then I lost the thread here, okay? Acknowledge what you hear, acknowledge what you don't, and know that breakdowns will happen. Like, this is aphasia, it's complex. I don't get it right, but a good part of the time, and this is my job. So it's just tricky at times. This is a little bit tougher, but can be a very valuable strategy to validate the person with aphasia. If you're in conversation with them and you're asking, hey, do you have any pain today? And they're saying, no, and you at the same time, like a beat behind, are going, no pain. Okay. So reinforcing to them, I got it. I understood your message. Thank you. And if you didn't get it, they might be able to jump in and say, no, that's not what I meant. They will do that, right? Asking clarifying questions. And again, presuming competence, right? Help them save face. We have to acknowledge that there is a power dynamic when we are in a medical situation as a provider and a patient. So our patients are already at a bit of a disadvantage because they might come to us feeling like, oh, this physician, this provider knows all the answers and I'm just the patient, right? So we need to really go and meet the patient where they're at if we want our care plans for these folks to be successful. Mix your communication modalities. So don't just talk at them the whole time. And also, and I've totally been guilty of this, don't just go to a website, print off the first handout you see for aphasia and go, here. All right, I gave it to them verbally and I handed them a sheet, because what do we know about reading? That could also be impacted. And if you're handing them something very dense, there is a very good chance that they might not be able to hang with that. I have graduate students without aphasia who I give regular readings to, and they're like, what is this? So we have to be, and they're very smart. We just have to presume that everybody needs the support for these resources to meet them where they're at. And finally, encourage and engage with the person with aphasia. So this is one of my pet peeves. And we do healthcare simulation at the University of Delaware, which is like a really fun, really cool, really tough way to learn without having an actual patient there, right? So we run these simulations where there are healthcare theater actors, and we have this big backdrop in the Star Tower, and usually it's like a hospital or something that kind of adds a little bit more to that sensory piece. Alarms are beeping, care partners here, and we go, okay, this person has aphasia, go in and introduce yourselves, and we see, hi, Mr. So-and-so, not the patient, right? Hi, it's so nice to meet you. I'm Christine, I'm the speech pathologist, but not communicating directly with the person who has aphasia. And that is a lesson that our students learn quickly and do not repeat. But that is a situation in which you have an opportunity to connect with that person and respect their confidence. So speak directly to your person with aphasia as much as humanly possible. And then at the end of your conversation, make sure to reinforce what you've just said. I'm breaking my own rule because you really shouldn't have more than 3 key ideas for a patient to walk away with. And then check in to make sure they don't have any questions, that they're really getting this through teach back, but maybe even following back up on them or with them a few days later, right? Again, to prevent the readmissions, to prevent the preventable. So my takeaways for you all are to keep framing, right? Aphasia is complex, but if we try even going a foot in the direction of our folks with aphasia, we're going to be able to give them more bandwidth to communicate with us, to really understand our plans. We may not have to use that non-compliant word, right? Because we've actually delivered our message in an effective way. Side note, I actually think this works for everyone, right? This is not aphasia specific. I think that this could really support us in taking responsibility for organizational health literacy, which is a big legislative push right now. It's no longer just the patient's responsibility to understand their condition, right? It's our responsibility to create information that meets them where they're at so that we don't have these preventable issues. There is our acronym for you, and I'm always happy to share this information. I've put my contact information here, and I will say that while I work at the University of Delaware, I am so happy to connect you with like whoever the closest SLP is to you. I will seek them out. I will find them. So if it's not our clinic, I will track down. There's so many wonderful therapists who really have an investment in supporting folks with aphasia. And my hope, right, I have a dream that SLPs can start to act as consultants for other providers, right? You're having a person with aphasia who comes in, they're not able to follow along with their home program. You've kind of tried all of your tricks and you're stuck. Call us. We'll come in for a visit. We'll start to communicate with you and the person with aphasia to kind of connect those dots and to help with that continuity of care, right? Because this is a team. This is what we do. There is information about the clinic. And I also want to briefly highlight our life participation groups as my final parting piece of information. We have created at UD these groups that are not support groups. They are not skilled therapy. They are safe spaces for people to practice their communication strategies. And you'll see here, I've included all of them. So these are not just for folks with aphasia. We also have brain injury caregiver groups. We have NeuroNotes, to be fair, is a choir for people with Parkinson's, but we've had stroke survivors join us recently and it's been awesome. We have groups for folks in the gender expansive community to practice their styles of communication, again, in a supportive and understanding group. So Aphasia has Brew Crew, and one of the originators happens to be here. Yes, Alexis Ryan. So, and I should be very clear that brew is for coffee. They gather around coffee to talk. We also have a movie club where the folks with aphasia come together and they have discussions about movies they watch, games. So we really try to reach out and bridge that gap between traditional care and life, right? Because that's what it's all about, getting back to life. So with that, any questions?
Hi, I had a question about someone with aphasia. I'm in acute care.
Yeah.
How imperative is it to start working with that right away as opposed to waiting till they're in an outpatient facility?
I'm so glad you asked that question, because I meant to start my talk by saying that I'm a speech pathologist and I do something other than look at your swallowing, right? We have this whole other domain. So what the literature is showing us in terms of intervention and rehab is that there is a certain level of medical stability where a patient needs to be, right? If they are really struggling with their pressures or struggling to maintain alertness, that might be too early for intense rehab. But there are other places that we can come in. So for example, that individual who's got spatial neglect, if speech pathology and OT can work together, we might be able to figure out, hey, we need to place the call bell differently. We need to give them access to something in a different way than how this is set up. Here are some strategies that you all might need to use when you're administering meds or checking pressures. Here are some of the key phrases that they might need to communicate quickly. So I think there's triageable things we can do immediately. And then as we start to hit that more medically stable space, then we have some bandwidth for really working and doing rehab. And the other piece that I'll add, we all know, I'm just going to presume this, that rehab doesn't stop after a year, right? There's that spontaneous recovery period. And then some physicians, some folks say after a year, you can't make any gains. We just objectively know that that is not true. I have seen remarkable gains in some of our outpatient and our intensive programs, 16, 17, 20 years post-stroke. So I never count anybody out. Good question. Thank you.